So we spent a lot of time in previous videos talking about unipolar depression. Now we're going to switch to a discussion of bipolar disorders. And you remember this slide is one of the most important slides for you to understand the differences between the various mood disorders. We went through that in another video. So the concept of bipolar disorder, we have descriptions dating over 2,000 years ago. But it took a guy named Emil Kraepelin to kind of have the insight about what this disorder is all about. So he worked at a German hospital which was full of people with psychosis or demence. He tried to make sense of these seemingly hopeless patients. He reviewed charts, he interviewed patients, and he found two distinct patterns: those whose symptoms began early in life and those whose symptoms began late in life. He assigned those patients who became ill late in life to a geriatrician, Dr. Alzheimer, and these elderly people with psychosis were eventually found to have dementia. The remaining patients fell into two groups: the young people. One was a progressive worsening psychosis, which he called dementia precox, we call schizophrenia. There was also patients with intermittent psychosis with periods of lucidity. He called that manic depressive insanity. Lifetime prevalence, bipolar 1, 1%. Bipolar 2, the old studies show 1.1%, but it's thought that the actual prevalence of bipolar spectrum disorders are anywhere from 2.6% in the minimum to 7.8% maximum. And my rule of thumb is basically that bipolar spectrum disorders exist in about 5% of the country. Average age of onset is 18 for bipolar 1 disorder, which is younger than unipolar depression, with 50% onset before the age of 20. Unipolar depression is in the low to mid-20s is when it starts. In bipolar 1, there's male to female equivalence. And remember, in unipolar major depressive disorder, females outweigh males 2 to 1. With bipolar spectrum, meaning bipolar 2 and cyclothymia, the ratio is 3 to 2 females to males. Bipolar 1 is associated with lower socioeconomic status, and in bipolar spectrum, individuals who suffer from the spectrum disorders have a higher socioeconomic status. So the first episode usually occurs in adolescence before the age of 18, and it's usually a depressive episode. There's no clue or hint that this kid is bipolar, other than that depression is the beginning at an earlier age. And patients with bipolar disorder do cycle between depressive and manic episodes, but most of these episodes are depression, not mania or hypomania. Almost always recurrent, with greater than 90% of individuals with a manic episode will develop recurrent mood episodes in their lifetime. It may not be next year, 2 years, 3 years, but decades later, it's possible to have another episode. If untreated, the episodes tend to become more severe and more treatment refractory and more frequent. They don't follow a distinct pattern. It'd be nice if you got depressed, then you got manic, then you got depressed, but there's no distinct pattern between when a person has a manic episode or a depressive episode. As I said earlier, the time between episodes can be years or even decades. Bipolar disorder has the highest suicide rate among psychiatric disorders. So up to 20% of people with bipolar disorder will kill themselves. Their impulsive behavior can lead to social problems, sexually transmitted infections, and legal problems. There's a high comorbidity with substance abuse. So here you have the general population, 20% with high-risk alcohol or drug use. If you take people with unipolar depression, that goes up to 27%. If you take people with bipolar disorder, you got 61% of these patients are at risk of misusing alcohol and drugs. Patients generally have poor insight when they're manic or even hypomanic. Manic episodes can be indistinguishable from schizophrenia. And it's also difficult to distinguish from alcohol and substance use disorder because, again, alcohol can lead to depression, cocaine and stimulants can lead to mania or hypomania, and so Is it the drugs causing this, or has the person got an underlying bipolar disorder? It's also difficult to distinguish from unipolar depression, especially if it's a person whose previous episodes were hypomanic, where they were feeling good and there was no gross dysfunction. They just think that that was when they were feeling well. And in the annals of medicine, it's rare that a patient goes to a doctor and say, hey, I'm feeling too good, can you do something about it? So bipolar 2 can be very subtle, and patients will present only with depression and they won't remember having ever been hypomanic. So to review the criteria, a person has to have an elevated or irritable mood with increased energy. You have to have both increased energy and these mood changes for 4 or more days, plus various symptoms of mania. And for a hypomanic episode, it's not severe enough to impair functioning markedly, doesn't lead to hospitalization, not accompanied by psychiatric features. So remember the DIGFAST mnemonic that goes through all the various symptoms of bipolar disorder. And the screen is, have you ever had 4 days when you're feeling so good, excited, or hyper that other people thought you weren't your usual self or that you got into trouble? And have you ever experienced 4 continuous days when you were so irritable that you found yourself shouting at people or starting fights or arguments? So those are the 2 questions to screen. If they answer affirmatively, then you go through the DIGFAST criteria. There's also this thing called the Mood Disorder Questionnaire, which can be very helpful to give people. You've got questions like, has there ever been a period of time when you were not your usual self and you felt much more self-confident than usual, you got much less sleep than usual? And if the person hits yes 7 or more times, that's a positive screen for bipolar disorder. How do you distinguish hypomania from happiness? In hypomania, a person's affect can switch dramatically. Cheerful, later on irritable. There's a drivenness and energy. There's less sleep than normal. There's grandiosity leading to poor judgment, and it's cyclical. If you look at happiness, the mood is even and not so easily disturbed. Patient, as opposed to someone hypomanic that can't settle down, someone who's happy can. And a big difference is full night's sleep. So when patient starts telling me about their good times, which I inquire about to be able to screen for hypomania, I ask them, well, were you able, how much did you sleep during that time? And they say, oh, I slept like a baby. Then I feel reassured that that was happiness and not a hypomanic episode. There's high rates of misdiagnosis. So here you see that patients coming in with depression, anxiety, or even what appears to be schizophrenia or personality disorder may be misdiagnosed when in fact they have bipolar depression. And it can take 10 years before a patient gets the correct diagnosis. So for bipolar 2 patients or cyclothymia, how do they present to healthcare providers when they're depressed, anxious? They may complain of mood swings, they can't sleep, and you'll notice even though they can't sleep, they still have energy during the day, but they would love to have a respite from their racing thoughts, irritability, etc. So they could be irritable, they may have fatigue, have difficulty focusing. I've seen people come in asking for ADHD meds when in fact they were having a hypomanic episode. They drink a lot, they abuse drugs, they may have trouble with the law, relationship problems controlling their impulses, or the majority will express no complaints, and if they're feeling good, why complain about it? So the differential diagnosis is difficult. Again, we have no lab tests that we can use, and I have a list here of all of the different disorders that can present to a psychiatrist. Psychiatrist has to be able to elicit whether this is truly bipolar disorder or is it any of the other disorders that I've listed here. So what happens if you make the wrong diagnosis? Well, if you don't recognize bipolar disorder and think it's just unipolar depression, of course the symptoms will recur because they'll be untreated. Each episode may become more severe and treatment resistant. There's going to be that increased risk of substance use disorders, legal problems, and even suicide. Remember, bipolars have a much higher suicide rate than many other psychiatric disorders. And these patients are going to have antidepressant misadventures, which means they're going to get an antidepressant, they'll become either manic, they'll become suicidal, it won't work, etc. So a lot of bad consequences if you miss this diagnosis. If, on the other hand, you call a patient bipolar and they're not, you're giving them a serious label, you're telling them you're going to need a lifelong, take this medication for the rest of your life, and the medicines we have for bipolar disorder are a little bit more side effects and toxicity compared to antidepressants. So this is a tough situation that most clinicians find, and there are those that err on the side of calling everybody bipolar, and there are those who err on the side of being very parsimonious in handing out that diagnosis, and there's someone like me who's kind of in the middle. Antidepressant misadventures. So a big trial called the STEP-BD, where there were hundreds of patients with bipolar who were depressed at the time, were randomized to one group received one antidepressant, the other group received a different antidepressant, and then a third group got placebo. All of them were on mood stabilizers, so they weren't on an antidepressant alone. So they looked at what are the depression scores 6 weeks, 12 weeks afterwards, and they found that adding the antidepressant to a mood stabler had no impact on the mood. You might as well just give them a sugar pill. People who take antidepressants who are truly bipolar can get agitated. They can have no response, partial response, or a response that poops out, meaning they relapse very quickly. They can start getting into a rapid cycle of mood swings. The antidepressant can induce mania, or it can induce suicidal ideation. So antidepressant misadventures are a risk of prescribing an antidepressant in a patient with underlying bipolar disorder. So this slide I would like you to memorize, because I think it's so important not to misdiagnose patients with bipolar disorder. So these are the red flags. I mean, sure, you try to elicit a history, but again, patients with hypomania, they'll look at that as just normal, they were feeling well, etc., and they now are feeling so low that they can't even remember ever feeling well. So you have to use other data to support your diagnosis of bipolar disorder. So anyone whose age of onset of their first mood episode, again, it could be depression, before the age of 20, that's a red flag. A family history that's loaded, what I call a family history from hell. My mother was schizophrenic, my uncle killed himself, and my brother's an IV heroin addict. In regular unipolar depression, you see family members with depression or anxiety disorders, but not a loaded family history like the one I just described. The course of symptoms, the most important thing here is seasonal pattern and postpartum onset. So patients who get depressed in the winter are happy over the summer. They're actually being hypomanic over the summer and seriously depressed in the winter. That's a tip-off this person might have bipolar disorder. Postpartum depression, and especially postpartum psychosis, also may reflect an underlying bipolar disorder. We talked about antidepressant misadventures, can also be a clue. And then current depressive symptoms, if they have atypical depression where they're overeating and oversleeping, if they've got a psychotic depression, or if they have a mixed episode with some depressive symptoms and some manic symptoms, those are all tip-offs that a patient might have bipolar disorder. None of these are pathognomonic. You can't just take one of these and say, hey, kid, this individual is bipolar. But if there are multiple red flags, you got to go think twice, think 3 times, think 4 times before prescribing an antidepressant without a mood stabilizer. So bipolar first-degree relatives are 10 times more likely to be bipolar than the general population. 50% of people with bipolar has at least one parent with a mood disorder. Bipolars can have unipolars, children, etc. And if you have a one bipolar parent, there's a 25% chance of a child with a mood disorder. And the mood disorder can be depression or bipolar disorder. 2 bipolar parents, the child has a 50% risk, and monozygotic twins have a third to almost 90% concordance rate. What causes mania? We don't really know. The biological mechanisms are not as well understood as in depression. The drugs that treat mania work by stabilizing neuronal membranes. So a lot of the anticonvulsants, valproic acid, carbamazepine, work via voltage-gated ion channels to kind of slow down neuronal transmission in the areas of the brain that are associated with mood regulation. Antidepressants, which increase all those monoamines, can induce mania, so it tells us that there is something going on here with the monoaminergic neurotransmitters. We know that cocaine and amphetamines and similar drugs can induce mania. And we know that dopamine activity is apparently increased in mania when patients are given antidopaminergic drugs like antipsychotics. Their mania often responds. So we know serotonin, norepinephrine, and dopamine are major players. We know that anticonvulsants work by stabilizing neuronal membranes, but beyond that, it's kind of mysterious. Drug treatments for bipolar disorder, we talked about the anticonvulsants, which I've listed here. Lithium is the gold standard rather for treatment of bipolar disorder. Antipsychotics and even benzodiazepines can be effective in helping treat bipolar disorder. Often you need to combine 2 or more drugs to treat somebody who's in a manic state. So lithium is one of the few drugs in psychiatry that's been proven to decrease suicide in both unipolar and bipolar patients. ECT is equally effective against mania and a depressive episode, and that's really interesting. And though ineffective alone, psychotherapy is a useful adjunct to medications. I would never say to a bipolar patient, just go to therapy, don't take meds. Polypharmacy is often necessary. Drugs that we have are more effective against manic states than depressive states. Antidepressants are often ineffective and occasionally can lead to misadventures. And unfortunately, compliance with medication in patients with bipolar disorder is often poor. Why? Because the patient will lack insight. They may not like the side effects of the drugs. And also they miss the grandiosity, the creativity that they had, the sensual acuity that they had when they were manic or hypomanic. So here's what a patient said. Ordinary mortals will never understand the manic state which I'm privileged to experience every few years. It's so vivid, so intense, so compelling. When I feel that way, there can be no other explanation. To be manic is ultimately to be God. God himself must be supermanic. I can feel it when mania enters through my left brain like laser beams, transforming my sluggish thoughts, recharging them, galvanizing them. My thoughts acquire such momentum, they rush out of my head to disseminate knowledge about the true nature of mania to psychiatrists and all other ordinary mortals. That's why I will never accept lithium again. To do so is to obstruct the divinity in me. So here I just test you with a few matching questions, so do that on your own, and I have the answer key right there on the bottom. Okay, and that concludes our discussion of bipolar disorder.